peripheral blood examination, we always talk about peripheral blood smears. Peripheral blood examination starts with cell counter, hematology analyzer. It's primarily the job of hematology analyzer is to count the blood cells. It is based on physical nature of the blood cell, whether it is in the natural form or modified by some reactions that the cell counter does. We know our cells, isn't it? We look at the microscope, we know our neutrophils, we know our lymphocytes, we know our reactive lymphocytes, we know our blast. But the cell counter also sees the cells in a different way, but exactly the same cell. The interest is now how to predict how much of the cell the hematology analyzer sees explains the natural phenomena or the abnormal phenomena that we know about. So the issue is, why do cell counters do better morphology than us? Because it analyzes cells 80 to 100 times the more than what you even see under the microscope, and also gives a proper output. So whenever I get a major 5-part analyzer, I want to know what part of the analyzer should I invest in or waste my time or invest my time in. Like for example, I was always using a Coulter VCS, volume is size, cell size. Should I use cell size in Sysmex? Should I use cell size in Mindray? Should I use cell size in Advia? Should I use cell size in Celldyne? So what I do is, whenever a new cell counter comes, I put the slide and one cover slip on my microscope. From this side I inject the blood, and from this side I put the reagent for the cell counter on this side. And I want to see what is the process that's happening. You must realize one thing. You must realize one thing. Cell counter analyzes cells and processes cells in 20 to 25 seconds. Don't imagine that, ये पूरा सेल मेरे सामने है, पूरा दिन मेरे सामने है. सेल काउंटर के सामने 25 सेकंड, nothing more than 25 seconds. So what happens to the cell before 25 seconds and what happens to the cell after 25 seconds, we don't know. So that's very important. You have the famous 70 minute. Anybody know 70 minute? How many of you know 70 minute? No, you have to ask here, man. 70 minute. Nobody knows 70 minute? Huh? Very good. Check the India. Okay. Now that you came to this question, how many of you know that Goa is famous for football? Okay. Can you name one football club in Goa? Can you name one football club in Goa? There are 4 famous football clubs in Goa. Last one is the new one. Sir? Wow. Punjab का वही बताएगा. Jalandhar wala. You are from Jalandhar, sir? JCT Pagwada had the best football team. Salgaonkar was one of them. Dempo, in fact, even Goans don't know there was a club called Sesa. The new club is called Churchill Brothers. Okay. Kerala has got any football club? Never had. Did you know, sir, any club? Where is the Reju? Reju is not here, huh? Reju, tell me one football club from Kerala. No idea, na? Premier Tires? Premier Tires had a very good football club. Yeah. So you must realize that when we actually invest time on a cell counter, you should know what the cell counter is doing. If you don't know what the cell counter is doing, why invest time on it? So therefore, what I do is, I put from this side, then I know exactly what's happening to the white cell in 25 seconds. So like for example, my first cell counter was Coulter, and I invested a lot of time on cell size. Then I said, oh, ये तो Sysmex भी हम कर सकते हैं, तो Sysmex भी 5-part differential है. Then I realized that Sysmex में छेद चल रहा है, and cells are shrinking. So size, don't need to look at size. So you need to know what's happening to your cell counter when the cell counter is processing the cells. because we know the cells. The cell counter also knows the cells, but it's been given an automated platform to analyze the cells. So you must realize that lysing of red cells is very important during the processing of differential count, because you don't want the red cells to come. Red cells are in millions, millions. White cells are a few thousands, not even 10,000, less than 10,000. So when you're talking about something in millions, you don't want them to interfere with white cell count. So you have, then of course, how are the cells being analyzed after processing? They go through one hydrodynamic focusing, so that they go in one by one, where the analysis is happening by laser. And then what is the analysis that the cell counter, see, for the Sysmex is not interested in size at all, because all their life they realize मेरे को छेद करना है तो सेल तो छोटा ही होगा, तो साइज में वेस्ट करने का टाइम नहीं है. But I'll show you that we can still waste time on that. So if you look at size, the only cell which does real size are DXH, alinity and humicin. The cells that use fluorescence for cells are XN, Mindray and alinity. Cells that use staining like peroxidase staining or some other staining are Advia and humicin. And cells that only look at nucleocytoplasmic content is DXH. But all cell counters look at granularity. Scatter is there for every cell counter. No cell counter ignores granularity. So, for example, you have got this cell, this is along the y-axis, x-axis is granularity, and this is volume, size. So, smallest size and smallest scatter is a lymphocyte. Cells which are same number as lymphocyte but having more size and more scatter than lymphocytes are the neutrophils. Cells which are the same size as neutrophils but having more scatter are the eosinophils, and that's a monocyte. Now here you have got the BC and the XN. Here, I'll tell you one thing, it's morphology. Have you ever tried to differentiate lymphocytes as small lymphocytes and large lymphocyte? Lymphocyte, basophil, neutrophil. We don't say large lymphocyte, small lymphocyte. This fellow can tell you what is small lymphocyte and large lymphocyte. So it's basically RNA stain. So you must realize that there is something called heterochromatin and euchromatin. Only me and Dr. Tanjir will understand that. Will you understand that? No. So that's our old language. So heterochromatin is basically, which is dark staining. In the neutrophil you can see the lobes. There's part of the lobes which is very dark staining and part of the lobe which is light staining. Light staining is called euchromatin. So this stain will tell you that there is euchromatin in this. So you can know that eosinophils has got the least euchromatin. That's why along the y-axis there is hardly any staining. And you can see here neutrophils which have got very low euchromatin. Small lymphocytes have low euchromatin, heterochromatin, low euchromatin, and then you can see that as they become larger and larger, they have more euchromatin. And monocytes are full of euchromatin. So based on the staining of the cell, छेद हो गया. So therefore, you only have y-axis staining of the cell, mainly the nucleus and the scatter. Obviously, the eosinophils has got more scatter. You can see that. Now here is basically the staining. You can see that peroxidase stain has got more staining. Now here also there is a peroxidase stain, but here what they show is look at granularity and light loss. So obviously if the cells takes more stain means more light loss. So you can see that neutrophils have got more light loss, eosinophils have larger light loss, but here you can see that eosinophils have got more peroxidase, but light loss is much less because eosinophils are somewhere here. So once you understand your cell counter, then you can work on it. This is alinity. Where is Raymond? He's gone, huh? Okay. So alinity is a cell counter which looks at only light. There is no staining, there is some staining for NRBCs, but it's mainly light. Even WBCs, RBCs and platelets are analyzed by size. So that is the scatter. So you can see that eosinophils and neutrophils are here. Eosinophils are here based on differentiation by polarized light scatter, and then you have got the lymphocytes here, the monocytes here. That's based on size. So monocytes are larger than neutrophils, and lymphocytes are the hardly scattering cells, and monocytes are the largest cells, but slight scatter, but not as much as neutrophil. So based on this analysis, now you can do your studies. Okay. Now, why do I depend on cell counters? Because cell counter, for us, neutrophil is under the microscope, 2 dimension mein. Cell counter sees the cell in 3 dimension. We don't see the cell as the cell counter sees it. And suppose there is an abnormal cell, it will come in the abnormal blast flag, and they will say this patient has got leukemia. So it's called suspect flag. But the problem is, a lot of systematic diseases like sepsis, malaria, dengue, they all undergo changes in the cells. And the cells are in the same place where the cells are. They will not come in a different population. So they will not be called suspect flags. They are within the same abnormal area. Only thing is for you to understand that they are abnormal, or they are changes that happen to the cell. Fortunately, some cell counters give you cell population data. I think there is a talk by Raymond today on cell population data. Most of the only 2 cell counters I get cell population data is from Sysmex and from, it's not difficult. If you have a scale, you can develop your own cell population data. But fortunately, some of the cell counters will tell you in this area what is the average size of neutrophils along the y-axis, along the x-axis and along the y-axis, what is the average size of neutrophil. It's like MCV. So some cell counters give it, even Sysmex also gives it. So we have, so whenever we do a study for using cell population to identify abnormality, we need to know that they are abnormal. So therefore, reference range is very important. Never do a study without reference range, because reference range is what you need to start your studies. Okay. This is Dr. Raymond's student. In fact, now he is Raymond's boss also in Coulter. Fernando Chavez, he was doing his MD. When we do MD pathology, he was doing his MD. So they said that, in sepsis, toxic change hota hai. What is toxic change for us? More granules. So more granules means cell counter mein more scatter hona chahiye. So they did a study on cell counter using to find out whether they can identify toxic change. It was a fantastic study. In fact, this is the first study we showed that cell counters can be better than any other parameter for sepsis. But the consistent finding was that the neutrophil was large in size. The intention of the study was toxic granules means more granularity, more scatter. They actually found that the scatter was low. If you look at the scatter is low. They ignored the fact that scatter is low, fine. But the finding of large neutrophil was significant, extremely significant. It's better than procalcitonin. So they published the paper with large size neutrophils means bacterial infection. So, so once, myself, Amardas Gupta, Dr. Manoram Bhargava was sitting with Raymond and trying to explain. He is very happy to see this paper, Fernando Chavez, your paper, though your name is not there. Trying to explain why there is no scatter. Why is there scatter? So that apna Hindustani chahiye. So we told that when a neutrophil comes from a blast, it takes 5 to 7 days. In a marrow, from a blast to neutrophil takes 5 to 7 days. And it undergoes 4 changes. One of the changes is that the nucleus becomes small, the blue color of the cytoplasm becomes grey because all the RNA gets converted into proteins and they become grey. So, change number 2. The granules start appearing in promyelocyte, in myelocyte, but after metamyelocyte, you hardly see the granules. That's because as the granules mature, they lose the sialic acid on the surface. So, when they lose the sialic acid on the surface, azurophilic dye, basophilic dye, attraction is gone. So, they will not, the granules are there, but they will not be stained because they have lost the attracting stain. And then of course, the size of the cell becomes half. But when there is infection, the marrow is in huge demand. You can see that only the nucleus undergoes the same change as the, this maturation happens in less than 1 day. What happens in 5 to 7 days can happen in less than 1 day. Only thing is the nucleus becomes, but you see the blue color doesn't completely disappear, the blue color remains behind as Dolly bodies. So, we all know that Dolly bodies is a mark of bacterial infection, but not many stains can identify Dolly bodies. The granules do not lose their staining property, they get stained. That's why we call toxic changes. Toxic changes doesn't mean increase in granules. It's basically the same granules, but have lost their staining property. So, it's basically a Romanowski mechanism. And also the fact that the size of the cell does not become half. So, large neutrophils, toxic changes, Dolly bodies indicates that these neutrophils were produced in less than 1 day, which can only happen in SIRS, which predominantly is created by bacteria. So, now the world is trying to look for a solution for sepsis, because sepsis is any investigation that helps for identifying sepsis is a life-saving mechanism. Procalcitonin, okay, but very expensive. Blood culture is very specific, but may not identify. So, there are a lot of mechanisms they are looking at where ideal test should be which is sensitive, which is specific, and also identify patients. So, this is a study that we did with, it was Nature publication, where we found that large neutrophils and low scatter of neutrophils, when you combine it with leukopenia and thrombocytopenia, the specificity of diagnosis of sepsis is almost 100%, 100%, and sensitivity is 91%. Just looking at neutrophil, nothing else, but from the cell counter. This is a study that we did in adults, where we had controls from ICU. Those patients who are SIRS, that's sepsis, those patients who are admitted in ICU because of hanging or poisoning or something like that, where there is no SIRS, we had those controls and we also had normal controls. So, compared to the ICU sepsis, you can see that neutrophil volume was higher than ICU controls compared to blood donors. This is the second study which actually identified that in sepsis, the second study in the world which identified that monocytes can also contribute to sepsis in the cell counter. So, we had monocyte volume also, which is higher in compared to ICU controls and blood donors. So, when we compared monocyte volume and neutrophil volume, the sensitivity and specificity of sepsis was almost 80%, which is good, better than procalcitonin. But we also identified that why do monocytes become important? Because when the neutrophil becomes large, the same number of granules, larger neutrophils, same number of granules, the scatter will be low. same amount of granules in the larger neutrophil, scatter will be low. So just imagine when neutrophils become large and they have low scatter, the neutrophils become, for the cell counter, it becomes monocyte. It becomes monocyte because larger cell, low scatter, go to monocyte. So this cell counter was identifying pseudo monocytosis. It was not monocytosis, it was neutrophils which was being identified as monocytes. So you can see that there is no monocyte here, there is no monocyte here, but the patient has got pseudomonocytosis. But when you have true monocytosis, you can see that you can identify monocytosis when a cell counter has got the histogram. You can identify true monocytosis. So there are certain advantages on certain cell counters that if your monocytosis is true, look at the histogram. If your monocytosis is not true, look at the histogram. It will give you the answer whether the monocyte is true or pseudomonocytosis. So there was a huge study that came from Netherlands or Belgium, the study that came from Erasmus, which talked about monocytosis as a very good marker for sepsis, and they came with a parameter called MDW, monocyte distribution width. You think it's a true parameter? It's not a true parameter, it's a pseudo parameter. So for a morphologist like me, when somebody markets a pseudo parameter, what's my job? Kill it. It's a pseudo parameter. It may be helpful, but it is not monocyte distribution width. It is pseudomonocytosis. You can't have a parameter using pseudo marker. So thanks to me, nobody markets MDW anymore. I don't know how many of you get to hear MDW. I am the reason for that. Because I told that, so thing is, actually it was Raymond's student from Russia. She doesn't look at the histogram, she only looks at scatter plot. So I told her, please look at histogram. If MDW is there, MDW should be in the histogram also. It's not there in the histogram. Her husband is a very good biostatistician. So she can convert anything into statistical significance. So this is pseudomonocytosis. You can see that. Look at the monocytes there. The neutrophils becoming monocytes. Larger neutrophils which have low scatter, they become monocytes. Now, sepsis, Dolly bodies. Have you ever seen? I'll tell you one thing. These are my slides, my own slide, nothing from internet. Look at Dolly bodies. Have you seen Dolly bodies like this in your life? So beautiful, na? Phenomenally beautiful in neutrophils. That's because I have developed my own Romanowsky stain, which is very cheap. Very, very cheap. I call it as modified right Jimsa. And what does that mean? That means there is remnant mRNA in the neutrophils. And you can see that the study that we did, same population of people, the neutrophil in patients with sepsis was higher. Look at this. In fact, they've got a few immature granulocytes also, but compared to this, the fluorescent in patients with sepsis was very high. And look at the area under the curve, almost close to 0.9. So increased fluorescent neutrophils in patients with fever, it's sepsis. Okay, coming back to the same patient, what is the difference between the two scattergrams? Here the neutrophils were larger, here it was smaller, but what you can see is there is no eosinophils in the patient with sepsis. There is a study in 1965 that was published in Nature which said that eosinopenia can be the earliest marker of sepsis than neutropenia. Neutropenia was always considered a marker of sepsis because You know, when sepsis happens, neutrophils are recruited, they all get shifted to the sepsis area. So neutropenia can be a marker of sepsis, but eosinopenia is a very specific marker of sepsis. Study was done in Vellore. Based on the study, after 3 years, I asked the ICU consultant, intensivist, what happened to the study? Oh, we found it was not significant. I said, Bugger, sometimes, you know, I get very angry. I said, Bugger, what reference range did you use? Because reference range that is used, all of us by 44 to 440 per cubic millimeter, na? Absolute eosinophil count. That is as per the European, our own 3000 people said that our reference range is 0.2 to 0.6. When we applied this reference range, the entire study became significant. The entire study, which was considered to be discarded as non-significant, became significant. So that's why I always say, whenever you do a study for cell population data, have a reference range. So this is the same population of people. You can see that patients with sepsis, the absolute eosinophil count was less than 100 compared to normal people, and the area under the curve was better than procalcitonin. So these are studies that we published. But you can imagine that, you know, guy calls me and says that, you know, I think my patient has got sepsis. I have taken the blood sample, the procalcitonin is normal. Can you look for toxic neutrophils? And I don't look at toxic, I don't look at smears at all. I go to the cell counter, I find the data, I said patient has got sepsis, but procalcitonin normal. I said doesn't matter. Anyway, you have to start, now that I have told you that sepsis, you have to start a line, you have to start a antibiotic. So when you collect the sample for, when you're going to start antibiotics, collect the sample, send it for procalcitonin, and procalcitonin is always more than 100. You know, there's a publication in New England Journal of Medicine which says that serial measurement of procalcitonin is a better marker of sepsis than single measurement of procalcitonin. You know, I don't know how much you charge for procalcitonin, but in Vellore it's 1,000 rupees. 2 sequential marker means 2,000 rupees. My cell counter is only 100 rupees. Of course, to the lab it's only 40 rupees. In 40 rupees, I am giving you a diagnosis of sepsis. Have you seen this? It's called pseudo-eosinophilia. So we have now finished pseudomonocytosis. Now we are coming to pseudo-eosinophilia. Have you seen this? These are neutrophils which have become more scattering. Why are they becoming more scattering? Because especially when they are in significant problem, you can have inclusions. It's called blue-green inclusions. Have you heard about blue-green inclusions? It happens when patient, but you can't see it in Leishman stain. You need a good stain like my modified right Gimsa, which is also very cheap. Have you ever seen a neutrophil with blue-green inclusions? Huh? So when you see a neutrophil like that, the patient will not survive beyond 48 hours. So when they showed me the scatter plot and this thing, so I called all my students and all my technicians and showed them that this is blue-green inclusions of neutrophils. And I said that people do not survive. So I called the patient carer. So one thing you must realize that, I don't know whether you notice, I don't call my people who are the bed carers, I don't call them clinicians, I call them as physicians, pediatricians, obstetricians, intensivists, because we are also clinicians. Please understand, we are also clinicians. Okay. So don't say, वो clinician ऐसे करता है, वो clinician ऐसे करता है. No, we are also clinicians. They are physicians, pediatricians, intensivists, obstetricians, but we are also clinicians. So you must realize this bed carer. So I called him. He's a pancreatologist who has a patient who is in acute pancreatitis. Liver has gone for a 6. So I said, Sudipto, what's your patient having? He said all these things. Why are you calling me, sir? I said, I'm seeing blue-green inclusion. He said, I can't understand what blue-green inclusion is. I said, when you see blue-green inclusion means patient will not survive more than 24 hours. So, okay. So, everybody around me, the students, everybody is listening to me. I put the phone down. After I put the phone down and they go back, every 2 hours they are checking whether the patient is alive or dead. Patient dies in 8 hours. After 8 hours, next day, all the technicians and students, not students, technicians, technicians, some of them are senior to you. They come and tell me, don't do this again. Don't do this again. You cannot play God. Very simple. You cannot play God. So now when I see this, I call them and said, whatever you're doing for the patient is not good enough. That's all I say. Not that your patient is going to die within 24 hours. So this is in your very simple early entry 5-part differential like 5130, which now Sysmex sells it as 560. You can identify sepsis. There is no eosinophils. And look at the neutrophils. Neutrophils have become larger than monocytes and they have got low scatter. So even a simple cell counter can identify sepsis. See, look at those neutrophils. They are large, they have got low scatter and they become larger than monocytes. And it's also causing pseudomonocytosis. So whenever a cell counter gives you pseudomonocytosis, pseudoeosinophilia, pseudobasophilia, don't blame the cell counter. Cell counter is telling you that there is something abnormal. Pseudobasophilia can be a diagnosis of dengue in Sysmex, old Sysmex analyzer, in Mindray analyzer. Pseudolymphocytosis can be a malaria diagnosis in Horiba and in DXH, Coulter. Pseudoeosinophilia can be a diagnosis of malaria in some of the cell counters. Pseudomonocytosis can be a diagnosis of sepsis. Don't blame the cell counter. Don't blame the cell counter because cell counter is basically identifying an abnormal population. Okay, so this is a patient who I have been following our staff kid, one of my colleagues' son who had dengue. So I have been looking at his peripheral smear. So when his platelet count is less than 1 lakh, you can see from normal platelet he starts producing large platelets. So this is when the platelet count is 10,000, 20,000, this is when the platelet count is 10,000. You can see the change in the platelets, from not only becoming large, they also become intensely stained. So not only are they young platelets, they are large young platelets and some of them are so blue, I call them as stress platelets. Same. Amen. You are my student when you are using that stain. So what is the importance of large platelets? We know that large platelet is something which is beyond physiological anisocytosis. Giant platelets are platelets which are larger than red cells. You can see when platelets are larger than red cells, they are called as giant platelets. So you don't loosely use the term giant platelets. Only if the platelets are giant, if they are more than red cells. Otherwise, you call them as large platelets. What's the importance of large platelets? That most of the cell counters use impedance and we can miss large platelets. But if you look at the histogram, you can see that they can accommodate large platelets. But when you have giant platelets, you got histograms like this. So look at the histogram. It will tell you whether you got giant platelets or large platelets. So MPV, is it a good marker of platelet physiology? No. It's not a good marker of platelet physiology. MPV is not a good marker of platelet physiology. Okay, let's look at optical platelet count. So now you have got optical platelet count by fluorescence or by optical method, light scatter. Light scatter is ADVIA and Alinity and fluorescence by Mindray and Sysmex. Okay, when you have a patient with Bernard-Soulier syndrome like this, obviously impedance platelet count is overridden by optical platelet count. But when you have normal distribution of platelets, where most of the platelets are less than 10 femtoliters, the impedance is actually a true parameter for platelet count. Because the fluorescent platelet count misses the small platelets as a fluorescent noise. You know, any of you do flow cytometry, you have noise, na? So small platelets are missed as fluorescent noise. So when you look at this patient, the impedance is 40, fluorescence 46. But look at the smear. So everybody asks, you know, what is the true platelet count? So you must realize that in the smear, the true platelet count is where you look at one platelet under oil immersion field is equivalent to 15,000 in the area where the red cells are starting to overlap. Where the red cells are starting to overlap, there one platelet is equivalent to 15,000, not anywhere else. Where the red cells are starting to overlap, one platelet is, there is a publication, is equivalent to 15,000. So you can see here, there are 6 platelets easily, platelet count is 90,000, but impedance said 40,000, optical said 46,000. That's because the impedance missed the large platelets and the fluorescent missed the small platelets. But what is the true representation of the platelet count? The histogram. So please look at the histogram. Never report your thrombocytopenia without looking at the histogram. And now here, this is a patient with dengue, you know, everyday platelets gone. So this is large young platelets, this is also young platelets. These are produced in the last one day. But because this platelet is large, it will be called IPF, and this platelet is small, it will never be called IPF. In fact, I don't even want to explain the term IPF. It's an insult to hematology. All my life, I have done 34 years of hematology. All my life, I call platelets only platelets. I didn't call them as mature platelets. I only call them as platelets. And because, you know, I diagnosed the highest number of Glanzmann's thrombocythemias and Bernard-Soulier syndromes in the world. I diagnose 50 new Glanzmann's thrombocythemias every year. Every year. They are not immature platelets. They are platelets, but they are not functional. Immature platelets, if you want. In fact, there's a nice article by Mario Plebani in International Journal of Laboratory Hematology, which said that please do not insult these platelets because these platelets are active, more active than normal platelets. Don't call them immature platelets. It's a beautiful article. It's actually an editorial. So we found that all those patients who have got large platelets, their IPF is more than 60%, and we know that IPF is a misnomer. And if you want to call something immature platelets, proplatelets, na? One proplatelet can give you 100 to 200 platelets. They are not as effective as 100 to 200 platelets. You want to call them? Call this fellow immature. Don't call platelets immature. You know, it was a study that came out of Bruce Davis, Sam Machin, because they came out with the IRF, immature reticulocyte fraction. And I had a nice study that came yesterday on IRF. They are the people who gave the term IPF, and they made a lot of money from IPF. They made a lot of money. So when I started opposing, like I opposed MDW, I opposed IPF. You know, Sam Machin called me and abused me. I said, you can abuse me, but don't use fraud parameters. Don't con people. Don't con people. And more than that, this conning is affecting patients. Don't con patients. Of course, poor fellow died. And Bruce Davis actually apologized to me. I'm meeting him next week 2 weeks later in Montpellier. We have the ICSH. So this is a study which showed that large platelet fraction is the same as IPF. Okay, this is an anecdote. I hope this becomes a study like previous anecdotes. The pediatric infectious disease doctor calls me and says that, Sukesh, one of your students has reported blast because they were immature reactive lymphocytes. Patient also had reactive neutrophils. But what impressed me was that, yeah, patient had a platelet count of 10 lakhs. A child who's having fever. You know, you realize that, sometimes there's a blessing of God. Immature, I mean not immature, one hidden blessing of God. When I joined CMC, whenever I reported this platelet count of 10 lakhs, my professor used to say, pertussis, whooping cough. Whooping cough can cause platelet count of 10 lakhs. Look for reactive lymphocyte and reporting it as, please rule out whooping cough. By the time I entered my second year, whooping cough disappeared from the world. My professor was very much there, but I was my professor's student who knew that high platelet count is whooping cough. So I said, ma'am, anyway, forgotten. So this child who had a, reactive lymphocytes had a platelet count of 9,000 with normal distribution. So I called Vince, do you think that this patient has got a bad cough? Just imagine, pediatrician who knows whooping cough very well and has not seen whooping cough, Winsley is a junior of mine. I don't think so. I asked whether the patient has got bad cough, thinking that he would have never seen a whooping cough in his life. So I said, does the child have a bad cough? So he said, like a whooping cough? I said, yes. I said, have you seen a whooping cough? Yeah, it looks like the child has a whooping cough. I said, the child has got pertussis. In those days, we are talking about 5-6 years back. He sends the investigation to for PCR testing because there is no culture for Bordetella pertussis. 2 days later, diagnosis is pertussis. Just imagine, that guy, that pediatric infectious disease was benefited by my being there because I was taught by somebody else who was such a great person. It is pure chance. So, you must realize that don't ignore your teachers at all. But only problem with this is that when the large platelet increases in the WNR channel, you can see these are platelets. When platelets become larger, they start going into the WNR channel and start becoming white cells. So when you have a platelet count with 55,000, where the white cell count is only supposed to be 5,000, they become counted as white cells. So always be careful about, so whenever you report the white cell count also, please look at the WNR channel. And especially if you are working in eastern part of India, because eastern part of India there is a lot of large platelets. A lot of large platelets will go into the WNR channel. Okay, yesterday we saw this. Dr. Tina's favorite picture. Huh? So these are monocytes which are infected by dengue virus. According to Raymond, it's not monocytes, they are lymphocytes. It's all right. But you must realize, why does this pattern, normally when you have reactive lymphocytes, they should go like this. And you can see that, there are so many cells which have got so much RNA that they are not even counted by the cell counter. And that's the reason why they take this particular direction is because they go along the monocytes. That's why the turn happens. While if you have reactive lymphocyte, it should go this way. It should go this way. So this is a very classical pattern that you see in dengue. And when you want to see dengue in other cell counters, you look for lymphocyte monocyte overlap. So BC 5130, simple cell counter. And my student, simple, one girl, village girl from Vellore, she says that it looks like inverted love. So you see this? An inverted love in dengue. That's because of some of the lymphocytes which we undergo. Yeah, correct. So this is when you have reactive lymphocytes, and this is when you have This happens in scrub typhus, but in scrub typhus the neutrophils also undergo changes. You can see the neutrophils are reactive, and they are not only reactive, they are very susceptible to changes. So even the forward scatter looks like a golf club. You know, dekha? This is normal, and look at, they almost look like a golf club. And these are the changes in patients with scrub typhus. Not only one change, increase HFLC, increase neutrophil fluorescence, and decrease FSC. And when you start the patient on a simple drug like doxycycline, look at the effect. All these parameters come down. So this is the one, pertussis, this is the one, sorry. I jumped up. I didn't know the sequence slide. So this is the patient who, he said your registrar called it as blast. Obviously, you can see that there are reactive lymphocytes there, and neutrophils are also not simple, they are reactive. But what is the platelet count? 10 lakhs. But look at the distribution of platelets, normal distribution, not myeloproliferation. This is when I said pertussis. KMS. Now, I get a call from a neuro ICU doctor, 43-year-old female. He says, he always calls me, no, now you must realize, not he calls me. I actually I live a tough life. I get all these doctors who call me like this information. 104 fever, procalcitron is 0.59. No source of infection we can find. So when I look at the blood film, okay, neutrophils are slightly reactive because they are large in size. There is monocytosis. There is slight monocyte lymphocyte overlap, almost like the previous picture. Then I run it on another cell counter. There also the neutrophils are reactive. There is monocytosis and slight increase in reactive lymphocyte. But the platelet count is 10 lakhs. 43-year-old female here. Whooping cough? Whooping cough? Can you think of whooping cough in a 43-year-old female? So, you must realize these guys respect me a lot. So, I can't call him and said, does the lady have whooping cough? So, I called him. Does the lady have cough? Because this neuro ICU consultant is a very rough and tough black and white guy. He doesn't answer, he doesn't want to discuss. He wants everything in black and white. I said, does this patient have cough? He said, no. I said, maybe a good idea to do X-ray. Because I thought that cough means that something has to happen in his lungs. X-ray is clear. What do you think it is? Then sheepishly, I told that when I see this in children, I call this as whooping cough. Maybe a good idea to send molecular testing for VP. Whooping cough, pertussis, Bordetella pertussis. Just imagine, sheepishly I am telling him that, in children, when I see this, I called it as pertussis. Anyway. So I told him, anyway, do a chest X-ray. Look at the message that comes 2 days later. You can see the life I live. If it was not Bordetella pertussis, I would have been happy. Now every bloody surgeon, when they can't, ID can't identify the infection, they call me. And 75% of the time, that's a study that was done recently, Sukesh's opinion versus cultures on PCR. 75% of the time, I am correct. Just imagine here. You can imagine how, this is only a small example of what I am presenting because I was asked to only present on cell counters. This is more dangerous. My teacher, my own teacher, not only teacher, the teacher of the best, all the good hematologists in the world, he undergoes a colorectal surgery because he got clear rectum and he undergoes anastomosis after the resection of colon. 4 days or 5 days he has a spike of fever. Normally 4 days, 5 days spike of fever means anastomotic leak. Classical. They do a CRP, CRP is high, take him for re-exploration. Result of re-exploration means morbidity is high, and if you don't take for re-exploration, mortality is 100%. So they are discussing, okay, spike is there. So the some surgical ICU consultant, whose son was having low platelet count, he said, let's check with Sukesh. So they called, and I've been, because it's this guy, I've been looking at smear every day. So he said, can you look at the smear? So I look at the smear, and what I can see, though he's got a white cell count of more than 30,000 every day, he doesn't have anything reactive. His neutrophils are calm, his lymphocytes are slightly reactive. You can see, his lymphocytes are slightly reactive, but his neutrophils are calm, and he's got normal eosinophils, no eosinopenia. I run in another cell counter, monocyte sources, neutrophils are calm. So I called and said, this is only viral infection. So, they were ready to take him to the theatre for re-exploration. And I said, it's only viral infection, there's no bacterial infection. So then the junior most guy calls me, are you sure? Then the professor of gastroenterology calls me and said, are you sure? Then the person who comes to ex-professor of gastroenterology who was in Vellore, who also came to help, he also calls me. His wife was my colleague. I said, yes sir, it's only viral infection. And he said, are you sure? I said, your wife only taught me because she was my colleague. So once you say the wife's name, everything comes down. They did not take him for re-exploration. And recently, I validated because I went on a trip with one of the guys who were there in the scene that day. And they said that Sukesh said, it's only viral infection. And he said, we were all shocked. But anyway, we did an ultrasound and those things. We didn't take him for re-exploration. Discharged 10 days later. Okay. So these guys, gastroenterology surgeons, they come and meet me and said, how could you even say that? Did you have the guts to say that? I said, what do you mean by guts? I only seeing the cell counts. No? If suppose you had missed that this patient actually did not have, if the patient had bacterial leak, he would have died. I said, you mean Maman? He said, yes. I said, oh my God, you don't tell me that. So now there's a study which is finished, which shows that cell counter can predict anastomotic leak. So we belong to a rich culture, so don't ignore ourselves. So we can predict anastomotic leak. Yeah, this is something that I presented last time. We are all taught anisocytosis, hypochromia, microcytosis, but nobody talks about anisochromia. Dr. Tejinder has taught his students about anisochromia. So 72-year-old gentleman, actually my uncle, they do a bone marrow because he had ischemic heart disease, he shorts up because his hemoglobin is dropped, his ferritin is 521. They planned for a bone marrow. So I said, send me a peripheral smear. So whenever you look at a peripheral smear on a patient with anemia, first thing you see is, are there polychromatophilic red cells? To show that erythropoietin is acting. Whether they are on external erythropoietin or their own erythropoietin, whether they have got, especially renal disease. And then what you see is whether the erythropoietin has got adequate iron or not. For example, this has got low iron, while this has got adequate iron. But at the same time, there is hypochromia in the red cells, and some red cells are normochromic. So that means anisochromia happens in the patient almost every day, because even the reticulocytes, some reticulocytes are hypochromic, some reticulocytes are normochromic. So my report to the nephrologist is that erythropoietin is adequate, because reticulocyte count is happening. Only thing is, some of the reticulocytes are hypochromic. Maybe it's a good idea to give some more iron. So during dialysis, of course, because he had ischemic heart disease, he was given 2 units of blood transfusion. But just 1 week later, of course, my uncle thinks I'm a magician. His hemoglobin was 11.2, of course, helped by the transfusion also. But from 6.5, his hemoglobin became 11.2. So sometimes, when you have, especially in patients with renal disease where you have hypochromic red cells, but hardly any reticulocytes, you know that erythropoietin is required. So you must realize that cell counter also taught me morphology, because we know that no polychromatophilic means no reticulocytes, anisochromia means hypo. So you must realize that something like CHR. So we have been looking at CHR, CHR is a science which was developed by Technicon many years back. They call the my algorithm. Most of the studies that have been done is basically looking at the parameters without looking at morphology. None of the studies have looked at morphology. How can we take people like us? How can we take it on face value? So we did one study. Yeah, we did one study and we realized that nahi hota. It doesn't go along with CHR is. So thing is, we said myself and Dr. Niti Matthews, my colleague, our report and CHR. Our report was more reliable for the nephrologist than CHR. When CHR was very aggressive and this thing, Raymond was in Coulter and everybody said, ask Ramon. Something has to be done. So then Raymond said, MCH is good enough. Yes, MCH is good enough. He came out with, they came out with RSF, he, though it's called red cell size factor, he calls it Raymond Simon factor. Yeah. So cell counter taught me anisochromia, earliest indication of iron deficient erythropoiesis, which is low hemoglobin in reticulocytes. Shift in HTW is probably the best indicator of iron therapy, and they were all taught by a cell counter to me. So use cell counters to also teach you peripheral blood morphology, in the sense that I have been a consultant to WADA. Have you heard of WADA? World Anti-Doping Agency. Headquarters is in Lausanne. Have you heard of Lausanne? Lausanne is in Switzerland. Is Lausanne anything, does it sound anything more to you? Lausanne? Lausanne is the headquarters of International Olympic Committee. So the headquarters of WADA is also in, and their best lab is in Rome. Gina Zini's husband is the head of the lab. So I am a consultant to WADA because when Commonwealth Games happened in India, I was supposed to do an audit for NABL, because they need to get accreditation before they can test. So they realized that if they cannot test, the samples will go to Singapore. So they wanted to get accreditation before that. So when I went there, everything I know, and that lady who was in charge of that lab was fantastic. But they also had 2 hematology parameters, and I had 2 NCs. I was the only person who had 2 NCs. I had the only person who had NCs, and she was shocked. So I told her, this NC is this, NC is this. Then she called Rome, she called all the WADA, the entire WADA place, and the entire WADA place asked, who is this idiot auditing you? But they said that his NCs are valid. But we closed the NC in 1 day. We closed the NCs in 1 day. One of the NCs, of course, was the cell wash. We used a centrifugal device. They didn't have a measure for the centrifugal device. The other one was that the reticulocyte count on the aqueous was always higher. So what was my solution? Is that because you are using you have this multiple tubes which shake samples. That was the biggest insult in hematology. You should never use, you can only mix samples this way, you can't mix samples this way. When you mix samples this way, it slowly starts distributing the cells. And when you take the cell and put it in the cell counter, it will go into one area where more reticulocytes are there. And they were getting high reticulocytes. So I said, don't use this. So they removed that, and they were doing very well. Not only that lab, other labs in the world were also doing very well. So, so, so every time when there is a important event and they suspect, hematology wise, I am consulted anywhere in the world, whether it is Olympics in Paris, in London. So this was a consult that came from Qatar. 5 hours before the World Cup finals. 5 hours before the World Cup finals, they said they are suspecting. I said, World Cup finals, mein kya? Why do you want hematology? Hematology is only used for endurance sports, like mountain cycling or marathon. You don't need hemoglobin for. But no, nowadays everything is going beyond extra time. Everything is beyond 30 minutes, and then after that penalty. So everybody is now probably looking at hemoglobin. So I was referred the sample. But this is an email that came. So I have hidden the names. And of course, they also hide the names of the person I am referring. So you can see that. So this can be Mbappe or Lionel Messi. But you must realize one thing. French people, majority of them are from the Mediterranean region. Even Argentinian team, their parents are from the Mediterranean region. All of them are thal carriers. And look at this. You have the white cell, red cell count, and look at the hematocrit. All of them have got low MCV. So anyway, I finally told that person that this person does not have any red cell transfusion, though he has got an additional population of cells which is probably less than 5%. You can see that there is an additional population of cells that this person has got. This is reticulocyte. He's got an additional population of cell. Maybe he is transfusion dependent, but he did not have transfusion for the World Cup. And you must realize the World Cup starts 1 month before the finals. All the preliminary match starts 1 month before. So, when you are going to give a report, you have to think about whether they are going to penalize the player. So I realized that it's not going to help, but I realized that this is far before the 1 month before the player had. So cell counter will not lie. One thing, I'll tell you one thing, cell counter will not lie. So this is the last case I have got. Shama has been giving me dirty looks. So this is actually when I was a resident I was doing my fellowship in hematology in Australia, and we get an abnormal call in the night, irritable child. The accidents emergency doctor calls me and said that child is irritable, can you come and look at and the child is anemic and jaundiced, can you look at the peripheral smear? We are very happy when we get this call, because every call you get $400. We are very happy. And so you go and register yourself, okay, that means $400 aa gaya. And if suppose you spend more than 4 hours, another $400. I am going to only spend 10 minutes here looking at a peripheral smear. But my $400 is insured. So he says that, okay, come. So I look at the peripheral smear, and it's such a easy peripheral smear here. What do I see in the peripheral smear? Bite cells, blister cells. Very easy diagnosis in child. So I called the doctor and said, oh, this is G6PD deficiency. It's a female baby. So then you start, okay, it's not G6PD deficiency, because we know that G6PD deficiency is a X-linked recessive disorder. Then you start, recessive type, autosomal recessive types of G6PD deficiency also seen and all those things. You start beating around the bush. He knows that I am now in deep trouble. So I know that 10 minutes is going to go beyond 10 minutes. So slowly I change my diagnosis from G6PD deficiencies to acute oxidant hemolysis, because obviously female baby. So he asks, what do you mean by acute oxidant hemolysis? I said, there are certain substances which are very oxidant stress, and it can cause Heinz body hemolytic anemia and this. So he asked me for an example. Have you ever, anybody's read any book on oxidant hemolysis? Williams, Wintrobe, anybody? In that list of things that cause oxidant hemolysis, what is the first thing? Fava beans. So I start with fava beans, and this is a child who is 1 month old. So you can imagine, when I start with fava beans, you can see that guy must be on the other side, must be thinking, what an idiot this guy is. So I start with fava beans, but this guy was so good that he goes and finds out that the second child wearing the clothes of the first child, which was kept in a box full of naphthalene balls, and this was caused by naphthalene balls. And I'll tell you one thing, that is what is called as competency. You know what is competency? Qualification, training, experience, and CPDP. That's continuous professional development program, that both of you are there, all of you are here. So now because of this, exactly a year later when I came back from Australia, one doctor from pediatrics calls me, Koshi, he is actually now a pediatrician in Tejpur. He says that I've got an irritable child, can you look at the peripheral smear? I look at the peripheral smear, I said this is GCP deficiency. He said it's a female child. I said go and ask the mother whether the child is wearing the clothes of the first child. So he goes. 10 minutes later he calls me, how did you know all this? So I said a good morphologist can look at the peripheral smear and tell what the child is wearing. So that's called competency. And of course you can see fragmented red cells in peripheral smear also. So cell counter does not hide anything. Don't blame cell counter for anything. Cell counter will give you the output that represents complete analysis of the cells in the blood. Understanding the disease process well, which is pathology, that's what we are. We get to realize the same is clearly displayed and objectively measured by the cell counter. Understanding, if translated into patient care, can overcome any deceptive clinical situation. Of course, more studies are required, but I will end my talk here. Thank you very much.